Okay. All right, well, good afternoon, everyone. Thank you so much for coming. Welcome to MRF HIV STI Echo. This is our 43rd session of the series. I am Dr. Boyce. I am your host to the most. To my right is Dr. Selena Todd. She will be doing a fabulous presentation on HIV and aging. It's a growing topic, it's a growing field, something we all need to know about, because as time goes on, our patients we started on treatment years ago are getting older. And more of our older patients are presenting with newly diagnosed HIV. So we all want to learn a lot. I'm really, really excited for the presentation. In the room with me is Conrad, and as well with Conrad is Dr. Barama. She's just for camera, but she is participating in a clinical observership, and she's with us today. So without any further delay, Dr. Todd, I turn the mouse over to you. Let me just start the presentation. Sure. All right. Are we okay so far? We see? Yep. Good. Okay, Dr. Todd, I'll go over to you. Or do you want me to practice?
Yeah.
Okay.
Can you do
All right.
Hello, good afternoon, everybody. Thank you, Dr. Boyce, for the introduction, and thank you for inviting me to present this on the ECHO program. The topic this afternoon is HIV and aging, and we can change the slide. Okay, so the linear objectives is to first start by dragging our feet globally. Let's look at the global trends among persons living with HIV. What is this term called the aging HIV epidemic? We look at some data in-house from the Medical Research Foundation. Then we will look at a controversial topic: does HIV accentuate or does it accelerate aging? Some non-HIV associated comorbid conditions, which goes by the monkey HANA, and Dr. Boyce would have done an extensive presentation on that topic a few weeks ago. HIV-associated neurocognitive disorders, which is HANA, and geriatric syndromes and frailty. Next slide. So during this presentation, you'd hear me always reference 50. And why am I using the number 50? The UN defines aging as 60. Some organizations are defining aging at 65 plus. The reproductive age is from 15 to 49 years. But it's a convenience in the literature because of how HIV affected persons' lifespans. The literature for anything with HIV and aging is 50 plus after the reproductive years. So you would always hear me reference aging in relation to the HIV population as 50 and over. So global trends among persons living with HIV, 50 plus. So the latest data is from 2015, and it says it has reported that 36.7 million people are living with HIV globally. In 2012, 3.6 million of those persons were 50 and over. In 2015, we have 5.8 million. So you see an increase of 2.2 million. And this trend is seen globally. Next slide. In all regions of the world. In Eastern Europe, Central Asia, even Africa, we are seeing doubling in the number of persons living who are 50 years and over with HIV. In Latin America and the Caribbean, we are not lagging behind. In fact, we are seeing tripling in the number of persons living with HIV who are now 50 years and over. In 2013, for the very first time since the epidemic of HIV started, they actually noted that at least 10% of persons living in low and middle income countries were actually over 50, while it was about 30% for high income countries. Next slide. So this just demonstrates, yes, we are seeing a global increase in persons living with HIV. You're seeing it both in lower and middle income countries as well as higher income. Yes, we are still lagging behind in low and middle income countries, but if you compare between 2000 to 2016 in lower and middle income countries, there was an increase from 7 to 14% in that 16-year span. And in high income countries, there was an increase from 15 to 35%. So persons are definitely living and aging with HIV. Next slide. So the aging HIV epidemic. What is responsible for these trends that we are seeing globally? It's two-pronged. One, the success of antiretroviral therapy, which helps to prolong the lives of persons living with HIV, as well as persons who are acquiring HIV at 50 years and older. So let's talk about antiretroviral therapy. This was introduced it's a cocktail of 3 drugs introduced in 1996 into clinical practice, and it has remained the standard of care. It is known to reduce the incidence of adverse events and early mortality in HIV-infected people. In 1996, the average life expectancy for someone living with HIV was 50 years. With its introduction, as of 2005, which was 15 years ago, it was 70 years, increased by 50 years. And now we tell all our patients that HIV is a chronic medical condition with a near normal life expectancy. But we also have to remember those who are now acquiring HIV who are 50 years and older, and I want us to be very mindful of that. So we have the success story of ART, but we also have to remember we are now acquiring new patients who are ART naive, who are now 50 years and older, who is being added to this pool of people living with HIV. And this is some data from CDC. This is their data, most recent data that they were released in 2018, which says 1 in 6 newly HIV diagnosed persons is 50 years and older. Yes, if you look at the data, you have your peaks in your 20 to 24, but the 1 in 6, so 1 in every 6 persons is already 50 years and older, right? Then we take a closer look at the people who have been diagnosed. Among the people who are 50 years and older, what are the demographics? What are the risk factors? And we're seeing it's really among men, it's among male-to-male sexual contacts for men, and among women, it's heterosexual contacts. Why are older people acquiring HIV? Because older people, one, there are several reasons. Older people do not perceive a risk of pregnancy, so they are more likely to engage in unprotected sex. The reproductive tract of older people are thinner, and it makes it more susceptible to HIV acquisition. They have more frequent doctor's visits, but the doctor is less likely to discuss sexual or drug use behavior among persons 50 years and older. Older people may have some of the same risk factors, but they are less knowledgeable about sexual risk and HIV prevention than a younger person. And also, data has shown that an older person is less likely to disclose their HIV status. There's more stigma. They may delay getting the care they need because they already face isolation due to illness, loss of family, friends, or community support. They are more likely to be ashamed and may hesitate to tell anybody that they are living with HIV. Now I want to share some of the data from our own Medical Research Foundation. We looked at our data. Next slide. Every new person who enrolls into care into MRF is issued a number. As of yesterday, our enrollment numbers were 9,903. So we have the first 1,000 persons, then the first 2,000, 3,000, and now in the 9,000 series. So we looked closer at the data. And in the first 1,000 persons who would have joined MRF, we currently have 548 of those who are now 50 years and older. So they have naturally aged. In the 9,000 series, which are persons who would have probably joined from last year, late 2019 to present, we have 236 persons who are now 50 years and older who are actually joining us at that age now. Next. So the first 1,000 persons, when MRF doors would have just opened, 57% of them were on treatment. Again, they were more likely to be males, 61.9% versus 38.1% females. We will have gotten about 54% viral suppression, and drug use was 73%, MSMs accounted for 22%. Then we look at the last 9,000 series, which is the present numbers that we are dealing with. We realize that we have more persons on ART, 86%, 60% of our viral suppression has increased. And again, men tends to outnumber women, same 2/3 versus 1/3 roughly. So 65.7% of the persons who are joining us in the getting 9,000 and something numbers are men, and 34.3% are women. The risk factors, again, previous or present drug use and homosexual contacts. So MRF data is reflective of the global data that CDC actually produced in 2018. More men, more MSM contacts among men, and we are actually enrolling more persons who are over 50 in our latter 2 years. Okay, so what is HIV and aging all about? There are two schools of thought, and there's no agreement in the literature as to which school of thought is superior to the other. So we will come look at them side by side. Does HIV accelerate the aging process, or does it accentuate the aging process? So in terms of accelerate the aging, HIV by itself, what they're saying is that, can you click down?
Sorry?
Change slides. Okay, let's look at this to actually get it a little bit clearer, and then we'll go back up. So in terms of accentuating HIV, the theory behind it is that cancers and multiple morbidities, which is the MM on the slide, is occurring at the same age, but more often among HIV infective participants than among HIV uninfected. So same age. So if you were supposed to get diabetes at 40 or colon cancer at 50, it's happening at the same age as somebody who is not HIV, but it's just for everybody who's living with HIV, it's probably occurring 1 in 4 versus say 1 in 8 for somebody who is not HIV. So that's accentuated aging. So having HIV is just increasing your risk of cancers and multiple morbidities. The accelerating aging now is that it's occurring earlier. So instead of planning to get diabetes, say at 40, if you're living with HIV, you're getting it at 20. So it's occurring earlier among HIV infected participants compared with HIV uninfected, and that there are more events occurring. So it's like a premature aging. So endometrial cancers, which are more common in a 60 age group, you'll find it happening in a 30-year-old HIV positive person. If we can just go back up to so some of the reasons for the accelerated aging, they want to say there are things like immune senescence, that the immune system in an HIV positive person, both your innate and adaptive, meaning what protects your skin, what protects in your body, is diminished in response to any foreign antigen once you are someone living with HIV. They also want to talk about this term called inflammaging, and that spelling is correct with 2 M's, and where they say there is an immune activation in persons living with HIV. What happens is that the telomeres, as your DNA, you know, a shoelacing has 2 plastic caps. As your DNA naturally divide and to keep your cells healthy, you need these caps to be always sealed. What happens with HIV is that the caps actually shorten, they fray off, the shoelacings have frayed ends, so it can't tie properly, it can't string through the holes, and you get less division over time, and that's how aging happens. And they think that's what's happening in people living with HIV. Also, it's very important to encourage our patients for viral suppression, to aim for viral suppression and to maintain it, because the studies have shown that even when you do achieve viral suppression, there's a background level of HIV replication that has been detected in persons from as short as 6 months to as long as 6 years that is ongoing in that person's body. There's also chronic viral reactivation within HIV patients. They have reactivation of herpes viruses, especially the CMVs in persons living with HIV, which adds to inflammation and the aging process. When they would have been first infected with HIV, the gut is one of your largest lymph systems, your largest defense, and that gets distorted. So your patients very often presents with nausea, vomiting, diarrhea. So you're losing a huge part of your immune system, and your gut never returns to its normal functionality. Also, your CD4 cells get depleted, and you have an increase in the number of CD28, CD57, CD8. Basically, those cells don't do much for a person. They add into your aging process. they've actually shown that HIV persons actually have an increased level of interleukin-6, and interleukin-6 has been associated with chronic illnesses and cardiovascular disease. So is it that the virus itself is activating all these processes in its body, in one's body, accelerating the aging process, or is having HIV in addition to I may be a smoker, I may not exercise, I may be eating fatty, greasy, oily foods and increasing my risk of cholesterol. I may be co-infected with hepatitis B, so I increase risk of hepatocellular liver cancers. I maybe have a lot of stress, psychological stress, socio-economical stress that is just adding. All of these things in the presence of HIV accentuating my aging process. So there's a lot of debate in the literature. No theory has been shown to be superior, so it's just something for us to keep in mind. The accelerating or the accentuating effect of HIV on one's body will eventually lead to non-HIV associated comorbid conditions. And that is what we are really seeing now. In first world countries, most HIV persons are presenting with non-HIV associated comorbid conditions. In low and middle income settings like our own, we are still seeing persons presenting with opportunistic infections such as toxoplasmosis, PML, oral candidiasis, thrusted in the mouth for the first time. Because of late presentation, late diagnosis, is really important for us to keep pushing the envelope about early diagnosis, testing, getting on treatment, so that those presentations become a thing of the past and we continue to see more non-HIV associated comorbid conditions, the HANA, that people should be presenting with. So Dr. Boyce would have done an extensive overview on the HANA conditions. I will just briefly touch on the topic again. So it's found that while we tell our patients they will live a near normal life, the literature has demonstrated clearly it's a near normal life, not a completely normal life, because there are HIV infected patients tend to be biologically older than their chronological age, and they do suffer from age-related problems. Renal disease, for example. We know that the prevalence among HIV patients are 3.5 to 9.7%. And the risk factors would be Black race, diabetes, high blood pressure, which is all very common in our setting here. Persons who would have presented late with low CD4 counts, that is CD4 is below 200, and who would have presented with high viral loads. In addition, our first line medication that 73% of our patient population is on using tenofovir difumarate, which tends to be a little bit more toxic to the kidneys. There's a lot of discussion about introducing tenofovir alphenamide, and we hope to get that to our client population, and that tends to be less toxic to one's kidneys. We have diabetes mellitus for the patients who are on protease inhibitors. It affects fat redistribution. The good cholesterol tend to be a little bit lower in HIV persons. Increased risk of high blood pressure, and persons who have high blood pressure should be screened for diabetes. People who are diabetic should be screened for high blood pressure. So there's an increased risk of diabetes. The literature is not clear as to the real gist of why it happens, but it's been suggested that these risk factors, the redistribution of the fat, we tend to find more HIV patients, especially those on a protease inhibitor, having more central obesity, more fat in the stomach, more fat on their shoulders, and it's that fat redistribution that increases their risk of a diabetic state. HIV patients are increased risk of osteoporosis and fracture, 2 to 3.7 times increased risk compared to the general population. Thinning of the bone, softening of the bone, 67%. Actual fractures, 15%. HIV patients also increased risk of hypertension, 35% versus 30%. So among persons who are below 50, it's about 30%. Those who are over 50 living with HIV is about 50%. And again, the reasons are chronic inflammation and the whole redistribution of the fat, which is lipodystrophy, as well as HIV activates the renin-angiotensin system. Basically, the system just is able to sense salt and water in the body. We hear patients say, I'm on enalapril, I'm on lisinopril. Those pills that those patients talk about is to block that RAAS system and manage your high blood pressure. Also, cardiovascular. There was a veteran aging cohort study which showed that persons living with HIV was 1.5 times more likely to have a heart attack, 1.7 times more likely to have a stroke. And again, some of it is lifestyle choices, smoking. So we need to really talk to our patients about smoking. Smoking Mary Janes are just as lethal as smoking cigarettes. One Mary Jane joint is equivalent to 5 cigarettes, and we need to let our patients know that. Insulin resistance, again, through the fat redistribution, high blood pressure, and the thrombotic markers. Remember, in the accelerated aging, they talked about increased D-dimers among HIV patients. Next slide. So this is just a graphical representation. If you compare the renal failure, diabetes, bone fractures, hypertension, and the cardiovascular disease, HIV patients tend to have a higher prevalence, the solid black lines, compared to the general population, which are the broken lines. Next slide. I'm just going to take the opportunity, because we're talking about aging and HIV, to look at the neurocognitive disorders, and we'll talk about frailty. So chronic neurological complications. Sometimes you're talking to patients, that's why it's really important when you interact with a patient to encourage them to have a caregiver, somebody they trust to come along to some of their appointments. Because we know approximately 50% of people living with HIV have some form of neuropsychological impairment. And this is actually a 3-fold greater risk of dementia in persons living with HIV who are 50 and older compared to younger HIV-infected patients 20 to 39 years. What are the risk factors for these neurological complications? Advanced age, a low CD4 count, low presentation, use of illicit drugs. If you've had cerebrovascular diseases, diabetes, high blood pressure, obesity, dyslipidemia, these increase your risk of cerebrovascular accident and multi-infarct dementia. Sleep disorders, obstructive sleep apnea, or psychiatric comorbidities such as major depression, anxiety, or bipolar. This is just the neuropathogenic mechanism that we'll go through very quickly. Basically, the inflammation that HIV creates, it eventually crosses the blood-brain barrier. The astrocytes, which are the cells in the brain that's supposed to actually present things to the brain. You have cells on your skin who would do that, but the astrocytes is particular for the brain. They get overexcited, and that's what you have increased glutamate and neuroexcitotoxicity happens, and that's what leads to neuronal injury and dementia that we talk about in HIV patients. So there's a classification for it. You might, among persons who are on treatment, so there's 30% where they're asymptomatic. They may show impairment in 2 neurocognitive domains, and it doesn't interfere with their daily function, and you can have a conversation with them normal. Then there are mild neurocognitive disorders where they show impairment in more than 2 neurocognitive domains, and there's mild to moderate interference in their daily functioning. Then there's the HIV associated with dementia, again, because of the great benefits of antiretroviral therapy. That's why we have to keep pushing patients and offering them at all interactions about the need to start treatment as early as possible. HIV-associated dementia is really seen in about 2 to 8%, where you have more than 2 impairment in more than 2 neurocognitive domain, and it interferes with your daily function. I also want to talk, I can't talk about HIV and aging and not talk about geriatric symptoms and frailty. So geriatric syndromes are defined as multifactorial conditions that result from deficits in multiple domains, including clinical, psychological, and environmental vulnerabilities. So your geriatric symptoms include falls, urinary incontinence, difficulty with activities of daily living, slow gait, meaning you're walking slow, sensory deficit. We hear patients saying, I can't feel my toes and my hands, especially on patients who would have been exposed to the earlier medication like stavudine, AZT. They talk about, or even patients who started treatment late, they talk about can't feel their hands and feet because of the nerve damage. It also includes things like hearing and sight loss and the neurocognitive impairment that we talked about. What these studies showed is that what they're finding, more than 50% of persons living with HIV who are over 50 reporting pre-frailty in about 56%. No problem. So frailty is an age-related syndrome of increased vulnerability to stress, predictive of major adverse clinical outcomes among HIV and non-HIV infected individuals. So it's based on 5 criteria, and it's based on this FRED criteria, which was established in 2001. And they look at things like weight loss. Is the client losing weight? And it's not that they're diabetic or have a thyroid problem. Are they just losing weight, muscle mass? Are they losing strength, endurance? Are they walking slower? Is their activity level slowing down? And we know that people living with HIV are more susceptible to develop frailty at earlier ages than the general population. The risk factors for frailty, again, is low current CD4 count plus low nadir CD4 count. So if you currently have a low CD4 count and you presented with a lower CD4 count, you're more likely to develop frailty. If you have other comorbidities, diabetes, high blood pressure, if you have co-infections with hepatitis C, it's the background inflammation and hepatitis C induces that leads to this frailty. If you have central obesity, which you're more likely to have, if you have social factors and they have documented low education. So just to start summarizing, it's important for us to care for people living with HIV who are 50 plus, to try and get them to be diagnosed, to have that conversation about sexual health and drug use, because there are many opportunities to engage with persons who are 50 years and older. They are more likely to have comorbidities. And to remember that they may be on a range of other medication, polypharmacy, that may interact with your HIV medication. So it's important to get that list of medication from them. So it's important for behavioral risk reduction, drug use. We need to always ask about smoking cessation, smoking, and to encourage smoking cessation, because we know that smoking reduces the risk of a cardiovascular event by 30%. So we need to encourage our patients. It's important for us to encourage our patients about movement, exercise. So while one of the things to talk about at the beginning of the consultation with a patient is, yes, your viral load is undetectable. Yes, your organs are not being affected. We need to see the whole person and talk about risk factors, exercise, diet, smoking cessation. We need to also screen for comorbidities. And I think here at MRF, we do a good job, because at least once a year, all patients get a random or fasting glucose level. At least once a year, all patients get a cholesterol profile done. We need to understand and take some time to talk and find out from the patient what is their family history about cancer, so that we can get our person screened. We have a lot of trouble, and I've noticed this just from my interaction here with men being so hesitant to be referred to urology, even though they have climbing PSA levels. So cancer screening for men, cancer screening for women. We have our women's health clinic now, and we have a cervical screening in place. So we are really offering more services in terms of the cancer screening. I've showed that the increased risk of osteoporosis, this might still be a little bit of a challenge for us. Black populations like us we tend to have more fat in our body. So thinning out the bones and osteoporosis might be less of a challenge, but it is recommended in the literature that persons be scanned for this at 50 years rather than 65 years for the non-HIV population. Also, social support for persons living with HIV. Because of the isolation, they feel it's important to try and reach out to them, make sure that they have caregivers who understand what's happening to them. So in summary, HIV is a chronic medical condition. The benefits of highly active antiretroviral therapy. People are living longer, and that trend is seen both in lower middle income and high income countries, and it's been seen globally from China to Africa to Brazil. It's a global trend. But we can't toot the aging that we are seeing among HIV patients just to the benefits of heart. We understand that we are having people being diagnosed at 50 years and older who are joining that pool. So we need to be a little more sensitive when we're dealing with that older age group, make it a little more comfortable for them to get tested or disclose their status. Yes, there's controversy in the literature about does HIV accelerate or accentuate aging, but regardless of the controversy, it is clearly established in the literature that HIV does affect aging and that persons living with HIV biologically age. There's an increased prevalence of HANA conditions, neurocognitive conditions, geriatric symptoms that we should screen for at all times. And health workers, again, just need to be a little bit more sensitive dealing with persons living with HIV who are 50 plus and older. Again, I'm repeating myself here, but just to the screening for multimorbidities, which we're doing very well here at MRF, the polypharmacy, the need to ask for polypharm of other medications. We're having patients in the clinic who are on blood thinning medications that go beyond aspirin that can affect our HIV treatment. So polypharmacy, and we want behavioral risk reduction in persons over 50. So not just the younger HIV patient. We need to ask about smoking, cancer risk factors, exercise, diet. So thank you very much.
All right, thank you, Dr. Todd, for, again, a very engaging and very informative topic.
Thank you.
So let's open the floor for anyone who has any questions or comments about how to ask Dr. Todd about the presentation or any aspect of the aging HIV, aging person with HIV. And if you can't unmute your mic where you are, you can always just type your question in the chat box.
Dr. Musa says, given the long waiting time for review after referral, would it be beneficial to refer patients with high PSA for post-treat ultrasound as they wait for urology review, given the unpredictable value of PSA levels?
Yes, I think it's important to help urology to help our patients. So yes, I think it reduces the time. Yes, the patient has to go on a waiting list to get an ultrasound, but instead of their first consultation with urologist, they are sent to do the ultrasound. I think if they come with the ultrasound during that first consultation, it sets the tone because it tells us immediately the sizing of that prostate as well as any back effects on the kidneys. So I think, yes, it's important that we can actually start doing something for the patient while they wait. I know urology appointments have gotten a little bit longer now, especially in light of the COVID. So we need to be advocates for our patients. We need to present the best case. So trends of PSA is not one PSA, and yes, some kind of radiological investigation would help establish, I think, for good consultation at the beginning.
And Maria is asking, can you please tell me what nadir CD4 is?
That's your original CD4 count. When you're first diagnosed, that's your baseline CD4 count. So if I'm diagnosed today and my CD4 count is 10, this is my nadir, that's my lowest CD4 count. But say I've been on treatment for 5 years and say in 2025, Dr. Boyce ordered a CD4 count for me, and my CD4 count is now 500.
Melinda asks, what was the population used for the study which indicated that neurocognitive disorders, particularly HIV-associated dementia, occurs with about 2% of the pop?
Okay, let me just go back to my slide. I will. This is a study from 2018. I can actually send you the link. It's called HIV-associated neurocognitive disorder, pathogenesis and prospect for treatment. It was published in Nature Review, Neurology, volume 12. So we could send you the link for that. I'll share that with you.
I'm seeing Ms. Reed has a hand up. Would you want to ask a question, Ms. Reed?
Yes, good afternoon, everyone. We have noticed that at Comtalk, a number of clients have developed an issue with pill burden, and I'm wondering, with the aging, have you all seen any trend with older persons who have stopped using the medication and eventually dying?
Yes, we do see patients getting tired, not just older persons, but even our younger HIV patients. And I mean, I don't want to be preemptive, but there's been discussions spearheaded, going full force, advocating on behalf of our patients by our medical director for more drug combinations that will be simpler and will be less interactive with other medications. So we hope that in the dawn of time, those things will become available to our population here at MRF and to the wider population of Trinidad and Tobago who are living with HIV.
Dr. Musa asks, what is the relationship between duration of HIV infection and development of NCD apart from age? Comorbidities, because you have these side effects. The protease inhibitors alone will increase your risk of diabetes because of the fat redistribution. So comorbidities, the HIV itself either accentuating or accelerating the aging process.
Dr. Todd, if it is, we could encourage especially over 50 to get their flu vaccine. So then that was included, like getting vaccinated, especially with COVID right around the corner. So we at MRF should encourage our clients to, and we offer it here, especially over 50, as you said, you know.
No, I agree. That point that Ms. Galindo just wrote, that's an excellent point. That's part of MRF is offering vaccines, and I think people, especially now, patients are asking us about COVID. Yes, that's the virus that's in front of us, but we are in flu season and we need to still encourage our patients, and MRF do offer those vaccines. Yearly flu, yearly influenza. So many patients are not willing to take up the yearly influenza. We offer the pneumococcal vaccines. A lot of our patients are not willing to take up the pneumococcal. So if we can continue encouraging our both men and women, the HPV vaccines, in decreased risk for cervical cancer, anal cancers, especially among our MSM populations. We offer the hepatitis B vaccine, which is important as well, because that's a risk factor for developing liver cancer. So yes, thanks for reminding that we do have our vaccine program, which is very much available, and it's available on multiple days to our patients.
So we also have a comment here that says, with respect to urology referrals, once we have a high PSA and a prostate ultrasound suspicious for malignancy in COVID-19 settings, and only with urgent ones, we can contact urology on call for the Spain General Hospital and get roughly 3-week to 4-week appointments for those particular patients. Dr. Parhu is saying that she started doing that, and it has been helpful in terms of ensuring they are followed up in a timely manner.
That's very good to know. Thanks for that, Dr. Pablo.
And you'll see that we've placed the link to the session that Dr. Todd shared in her presentation. So that is in the link in the chat box there for everyone to take a look at as well.
Okay. So if there are no other questions, we'll just again thank Dr. Todd for a fantastic presentation. Thank everyone for interacting and asking such great questions. So just shuffle across the case, let's pull it up, and hope the technology doesn't beat us up. Just